Hello, and welcome to the Oregon Nurses Association's webinar on Oregon's new nurse staffing law, also known as Senate Bill 469. To give you some history about the bill, in 2001, Oregon State Legislature passed Oregon's first nurse staffing law with support from the ONA. That was actually one of the first nurse staffing laws to be passed in the United States. In 2005, the state legislature and ONA significantly updated the law. That gave us HB 2800, which we've been operating under for the past 10 years. In 2012, ONA's House of Delegates called for a review of the staffing law after finding we've had an increase in staffing request and documentation forms in situations of unsafe staffing. In 2014, ONA's House of Delegates voted to approve an action report as a guide for staffing changes and made improving the staffing law a top priority. In the 10 years since the staffing law has been updated, we've seen increased research on the dangers of inadequate staffing, increased financial pressures on hospitals that negatively affect nurses and patients, and increased reports of inadequate staffing by Oregon nurses through the SRDFs, or the Staffing Request and Documentation Forms. As an example, nurse staffing research has been going on for a really long time. Here's an article that I found from March of 1949 entitled "The Economical Use of the Hospital Bed and of the Nurse." For as long as there have been nurses, there has been research about how to use us most effectively. The 2014 Staffing Action Report that I mentioned earlier wanted to strengthen staffing committees and empowers committees' direct care nurses, improve working conditions around mandatory overtime and meals and rest breaks. It wanted to give the state new tools to actively enforce the law and increase transparency at the hospital and state level. It also wanted to create an advisory board to increase state accountability and identify staffing trends and problems. Diving into the actual literature of the law, we'll start by going over what the law now says about staffing committees. Staffing committees' decisions are final and must be implemented by their hospitals. Under the previous version of the law, staffing committees' decisions were simply taken under advisement by the C-suite, by the CNO and CFO and CEO of the hospitals. But with the changes that we made in the legislation, staffing committees now have the ability to change the trajectory of staffing at a unit level. And the committee members of that staffing committee have an incredible amount of power to be able to change conditions for nurses at the unit level. Staffing committees will be made up of 50% direct care staff and 50% nurse managers. That has not changed. However, now a non-RN staff member whose services are covered by the staffing plan is going to be joining the staffing committee as part of the direct care staff's 50% membership. This can be a CNA or a HUC, anybody who's covered by the staffing plans, and would make a good representative for the rest of those service members. Also, direct care nurses and the non-RN staff member will be selected by their bargaining unit if they're represented by a union. To talk a little bit more about the staffing committees must review plans at least yearly. In reviewing the plans, a hospital-wide staffing committee shall consider patient outcomes. That can be your readmission rates, your falls, your adverse events. It can be anything that your unit really tracks. Also, they should be reviewing complaints regarding staffing. Those are the SRDFs, the unsafe staffing forms. The staffing committee should be reviewing aggregate hours of mandatory and voluntary overtime for each unit and system-wide. And the staffing committee shall also consider the percentage of shifts for each hospital unit when staffing differed from the staffing plan. Staffing differing from the staffing plan can simply be being shorted a CNA. Anything that the staffing plan doesn't talk about can be differing from the staffing plan. And then upon review of staffing plans, the hospital-wide staffing committee shall report whether the staffing plan ensures adequate staffing or the staffing committee has the ability to modify these staffing plans to ensure adequate staffing to meet patient care needs. The staffing committees have become an incredibly dynamic piece of committee work within your hospitals. A direct care nurse and a nurse manager will serve as co-chairs of the committee, and the staffing committee must meet quarterly or at the call of either co-chair. Staffing committees will look at patterns of mandatory overtime and voluntary overtime, and that's system-wide, not just unit-specific, with the hope of being able to identify hotspots where overtime is being used in excess. Also, a quorum is required to meet and make decisions. If there's unequal numbers from either the direct care staff or the managers, each side will only have an equal number of votes. For example, if 4 nurses show up to the meeting, but 6 managers show up to the meeting, only 4 of those managers would be able to vote. These new staffing committees should have been formed on January 1st, 2016. Let's start talking about staffing plans. Under the new law, the staffing plans have to have admissions, discharges, transfers, rest and meal breaks, and additional non-care tasks, such as charting, to factor into the plan. It prohibits the sole use of external benchmarking measures to determine staffing levels, and they must be based on acuity and not a simple straight ratio or a grid or a matrix. They must also include a formal process for evaluating and initiating limitations on admissions or diversion of patients. That doesn't just apply to emergency departments. Any nurse on any unit has the ability to say, I don't think that we can safely care for any more patients. And then a hospital must also maintain and post a list of on-call nursing staff or agencies to provide replacement staff in the event of a vacancy. These new staffing plan elements must be included in plans by January 1st of 2017. If you need some assistance in figuring out how to put admissions, discharges, and transfers into your staffing plans, please contact ONA's professional services, and we'll be happy to assist you. The new staffing law also talks about replacement staff. This text is taken directly from the bill, that when a hospital learns about the need for replacement staff, the hospital shall make every reasonable effort to obtain nursing staff for unfilled hours or shifts before requiring a nursing staff member to work overtime. With that being said, let's talk about the overtime provisions that Senate Bill 469 addresses. Hospitals may not require a nurse to work beyond the agreed upon and prearranged shift, regardless of the length of that shift. If you were scheduled for 4 hours, you are simply required to work for 4 hours. If you're scheduled for 8, you only work 8. If you're scheduled for 12, you only work 12. A hospital may also not require a nurse to work more than 48 hours in a hospital-defined work week. They may not require a nurse to work more than 12 hours in a 24-hour period, and those hours do not need to be consecutive. They may not require a nurse to work during the 10-hour period immediately following the 12th hour worked in a 24-hour period. The law provides for nurses to have an adequate rest period between their shifts. And then time spent in required meetings, educations, or training shall be included as hours worked. The law does not affect voluntary overtime. Nurses are still allowed to volunteer to work whatever hours they would like. And these new provisions took effect immediately upon bill passage in July of 2015. A lot of nurses who work in the OR or the PACUs or in procedural services have to do some on-call hours. And the law speaks to that as well. Time spent on call or on standby when the nursing staff member is required to be at the premises of the employer shall be included as hours worked. And then if a nursing staff member believes that a hospital unit is engaging in a pattern of requiring direct care staff to work overtime for non-emergent care, that nursing staff member may report that information to the staffing committee. In the event that a staffing plan is unable to be approved by the staffing committee, the bill has built in a mediation process. So if the staffing committee cannot agree on a staffing plan, and this is over a period of time, not a single instance within the staffing committee, but a repeated series of an inability to agree on a staffing plan that's well documented within the minutes of the staffing committee. If they can't agree on a staffing plan, then either co-chair may call for a 30-day pre-impasse period by making a phone call to the Oregon Health Authority. After 30 days, the Oregon Health Authority will lead a 90-day mandatory mediation process for the committee. And then staffing plans made during mediation must meet the same standards as non-mediation staffing plans. And if there's no agreement after 90 days of mediation, the Oregon Health Authority may fine the hospitals. These new impasse rules must be implemented by January 1st, 2016. Hopefully, we can avoid using this process, but it provides a tool to help us come to an equitable agreement. Another major change in the staffing law is the enforcement piece. Under the enforcement provisions, it requires the Oregon Health Authority, the state, to audit each hospital at least once every 3 years. Under the previous bill, the state was only required to audit approximately 7% of the hospitals in Oregon. And we just went a little bit further and defined it as each hospital once every 3 years. And it will be unannounced along the same lines as a JCO or a DNV survey. The bill also states that it requires the state or the Oregon Health Authority to initiate on-site investigations within 60 days of receiving a complaint. We had multiple reports of hospitals who had made staffing complaints to the Oregon Health Authority under HB 2800, and it took the state in upwards of 14 or 16 months to come in and investigate. The law also requires a state to resurvey facilities with approved plans of correction within 60 days of plan implementation to ensure compliance. There were numerous stories of hospitals who had been found deficient in areas of staffing by the state. The hospital had written a very nice repair report on how they were going to address those concerns, sent it off to the Oregon Health Authority where it was stamped with approval, and then nothing ever happened. And we had members come back to us and say, we had our investigation, but nothing ever changed. So we built this piece into the law to really build in some accountability. And these new enforcement provisions took effect immediately, again, upon bill passage in July of 2015. As you remember, the action report also sought to increase transparency and accountability. So now hospitals must post information on the staffing law and how to report a violation in each unit. And that was required by January 1st of 2016 of this year. Audit results, when your hospital is audited, will now be shared with the hospital and the staffing committee co-chairs. The investigation and audit reports of violations and plans of correction will also be posted online, and these accountability provisions took effect immediately. Under Senate Bill 469, we also built in some oversight. We created an official statewide staffing advisory board, which is going to identify staffing trends and problems. They will be making staffing recommendations to OHA, and they will report annually to the legislature and may make recommendations for future legislation. This Nurse Staffing Advisory Board, as it's called, is kind of like a super staffing committee. It's made up of 50% direct care staff and 50% managers, taken from all over the state from a wide variety of practice settings. They will also be the ones who are making the rules, the Oregon administrative rules for the new staffing law as well. So just to review the implementation deadlines, the enforcement provisions, the accountability provisions, and the overtime provisions took effect immediately upon bill passage in July of 2015. The new staffing committees must be formed by January 1st, 2016, and the new impasse rules were implemented on January 1st of 2016. The last piece to be implemented will be that the new staffing plans must have those added elements by January 1st of 2017. If you have any questions or suggestions, or you want to learn more about staffing, please contact Professional Services at the Oregon Nurses Association. Email either at practice@oregonrn.org or give us a call. We'll be happy to assist you in whatever manner we can. Thank you for watching this very important webinar, and thank you for your support. Without our members, we never would have been able to pass this important staffing legislation in 2015.